Well, hello and a warm welcome to today's video on fluoxetine, one of the most common psychiatric medications in the world, actually. And just remember, all these medication videos are for kind of educational purposes, and medications just make one part of a holistic plan in mental health. But fluoxetine is an important medication. It's often first line for a couple of disorders, so very important to talk about. We're going to go through the therapeutics, so what it is, how it works, what are the indications. We're going to go through the common side effects, the kind of common doses, and we're also going to talk about special populations. So if pregnant people, breastfeeding, older people, younger people, issues with liver and kidneys, we talk about all that. And then finally, we'll go through some tips and tricks. If you find this kind of content helpful, please consider liking the video and subscribing to the channel. And other than that, let's get into it. So for the therapeutics, the brand name for fluoxetine is Prozac, and it's classed as a selective serotonin reuptake inhibitor, which means it blocks the SERT transporter, and that basically means that there's more serotonin in synapses between neurons in basically all the brain. The theory is that having more serotonin in those synapses is correlated to improvements in depressive or anxious symptoms, and also is related to neuroplasticity and essentially the ability for healthier neuronal pathways to form, helping reduce symptoms long term. The strength of evidence showing exactly how it works in the human brain is limited. It's very hard to actually know how medications work in the brain, and there are many medications, not just psychiatric ones, but also physical health medications that we don't completely understand. And actually the way we find out that they work is through large clinical trials with thousands of participants. And we see that when people take the fluoxetine instead of a placebo, when they don't know which one they're taking, the group who take the fluoxetine have better outcomes. So it is effective for multiple indications. It does come at a cost. There are some people who get side effects with it, but let's go through that in a moment. So the kind of commonly prescribed indications for it, here's a bit of a list. So it's sometimes even first line for major depressive disorder, and that's for people aged 8 or over, obsessive compulsive disorder in people ages 7 and older, premenstrual dysphoric disorder, bulimia nervosa, panic disorder, bipolar depression, but with bipolar disorder, you have to be very cautious with serotonergic medications like SSRIs because it can trigger a manic episode, and so they've made the caveat there to say that it's used in combination with olanzapine. And treatment-resistant depression. They talk a bit about social anxiety disorder, post-traumatic stress disorder as well. Interestingly there, it's not mentioned that it's used in generalized anxiety disorder and other anxiety disorders as well, like phobias. So, these are the common indications, but it's also used in other indications as well. In terms of how long it takes before it works, tends to be a matter of weeks. With SSRIs, what typically happens is first 2 weeks you kind of get some changes in energy levels and actually increased energy levels. Some people might find that unpleasant, and in some people that's correlated with increased suicidal ideation, which can make quite an agitated state. The evidence doesn't show, though, that there's an increase in suicide events, just that in some people who are very depressed, that the increase in energy can be correlated with suicidal ideation. And then after the first 2 weeks, you start seeing some of the mood improvements, and that can usually continue up to 8 to 10 weeks. So typically what would happen is you start at a low dose, it increases after a week, then you see how that goes for a couple of weeks, and then if there's no response after 2 to 4 weeks, you might bump the dose up again and kind of work with your doctor to find what the right dose is. If there's no response to a effective dose and the dose has gone up by 8 weeks, typically you would change antidepressant or try something else. You should see something by 2 months. And typically, from clinical experience, you would see something within 2 to 4 weeks, I would say. Just something. You might just find a 10% improvement or something like that, yeah. It's not always a medication you need forever. If you've just had a kind of single depressive episode and then you treat it with fluoxetine and it gets better, you don't need to take the medication forever. But if someone is getting recurrent depressive episodes or recurrent anxious well, like severe anxiety that's chronic, then sometimes you do need to take it indefinitely. Commonly, people do get a partial response. So after 2 months on fluoxetine, they might find that they have improvement in mood symptoms and energy levels, but actually they still can't sleep or something like that. It would be a partial response. And so it's very common for it to be used in combination with other medications, or maybe the dose needs to be adjusted. And often if there's only a partial response, like my strongest recommendation is to always do therapy with medications, because medications can kind of put you in a place where you're ready to engage in therapy and use the kind of different techniques and tips that the therapist works on with you. So if you have, for example, a treatment-resistant depression, then like often the case is that the fluoxetine will help, 30 to 50%, but then therapy is needed to kind of get the maximum benefit towards 80-90% reduction in symptoms. Okay, now we talk about the side effects. Most of the side effects that occur with fluoxetine are thought to be from the kind of serotonergic action, its effects on increasing serotonin, and most of them will get better in time. So the common advice is just watch and wait. And if you're getting side effects, hold the dose until the receptors adapt, because your body is adapting to the new, the new milieu, the new environment of the neurons. So, that is the therapeutic response of the body, is to change the receptor densities of different neurons. So if possible, it's always a good idea to persevere if the side effects are minor. That's the general advice. If you're worried, though, you have to talk to your doctor. The common side effects, I guess the first ones are sexual side effects worth noting. So serotonergic medications do come with sexual side effects, and those that tend to be dose dependent. So that's things like inability to orgasm in men and women, delayed or retrograde ejaculation, so kind of just odd timings of ejaculate, and reduced libido, so reduced sexual desire. So that's one domain of serotonergic side effects. The next is kind of the gastrointestinal system, and that's upper and lower. So the upper is kind of nausea, reduced appetite, dry mouth. Those can happen with fluoxetine, and then the lower is like diarrhea. And in my texts here, it talks about constipation, but I haven't seen that with fluoxetine. And as I commented before around side effects, it can be activating, it can give energy, and so that can affect your sleep. So it can be related to insomnia early on, and also if there's a bipolar depression, and sometimes you don't know if it's a bipolar depression. If there's never been a manic episode, how would you know it's bipolar and not kind of unipolar depression? So if you're finding that there are kind of early warning signs of a mania, that needs urgent review. And typically SSRIs in people who have a diagnosis of bipolar disorder really needs to be given with a kind of mood stabilizer like olanzapine. And worth remembering, especially in elderly folk, that all SSRIs come with a risk of syndrome of inappropriate antidiuretic hormone, which means it can affect your sodium levels. And that would present as kind of confusion and sweating and just looking sick. Like it usually comes as what's called a delirium, and people just look off. They're just kind of confused, disoriented, sometimes quite hyperactive, sometimes quite underactive, and you'll just feel something's off as an observer. And so that's an emergency. If someone has any new onset confusion after starting fluoxetine, straight to the doctors. Now there are kind of ways to address side effects with other medications. So for example, if someone's having insomnia, then your doctor might prescribe something to help with the sleep. You don't want to fall into the trap of kind of having another medication to kind of treat the side effects of the previous medication and then ending up with too many medications. Less is more with medications generally. And if you're having intolerable side effects, you can just try a different SSRI, something like sertraline or escitalopram, and those and just because you have side effects with one doesn't necessarily mean you'll have a side effect with another. But just again, the side effects tend to be time dependent and dose dependent, and so they will reduce over time, and you can always reduce the dose until the side effects abate and reduce, and then go back up in the dose. So if you started at 20 and you find that you're getting nausea, you can I'm not telling you what you can do, talk to your doctor first, but an example is that someone could cut down to 10 for a week or two and then go back up to 20 when their side effects reduce, and then see how that goes. The typical dose range in adults, 20 milligrams is kind of considered the minimum effective dose. It can go up to 80, and particularly in people with kind of obsessive compulsive disorder where higher doses of SSRIs tend to be used, it would be towards the 80 mark. In bulimia nervosa, it's dosed higher as well, around the 60 to 80 mark. It can come as many different forms, so it can come as tablets, capsules, and liquid. So in terms of the tips and tricks, fluoxetine has a very long half-life. It's a 7-day half-life basically. So you might find that it's a longer time before you start seeing some improvement in symptoms. But the advantage of that is that it's less likely to cause discontinuation syndrome if you're stopping it, because it's such a smooth, gradual drop-off. Typically, fluoxetine is in capsules, which makes it hard to, you can't break them in half. But if you can get tablets, then you can break them in half, and that can save you money. So if you're on 20 milligrams, you could ask for a 40 milligram tablet and crack it in half, and then you get twice as many tablets for half the price. So that's a really economic way to do it. People who need really low doses, so children and people who are quite anxious. So the more anxious, the more agitated a person is, the lower the starting dose. There are liquid formulations, so you can even dose 5 milligram starts, or you can cut a tablet in 4. Again, it can't be a capsule in that case. In my notes, I'm just reading now, and I didn't know this, but there's a weekly formulation. I don't think that's available in Australia because I've never heard of it. So you just take the tablet once a week. And then there is a combination formulation available with olanzapine and fluoxetine, which if someone's really stable and there's no dose changes and they have issues with tablets, then that's a good use case for a combination tablet. But typically I like being able to adjust dosages so that if there's too much sedation, you can just change the olanzapine, or if there's weight gain, or it just gives you more freedom if you have 2 tablets rather than a combined tablet. But if someone is stable, it's worth knowing that there is a combination out there. And then the final tip is, if you're finding that the activation of taking fluoxetine is too much and it's almost agitating, then you need to talk to your doctor about the possibility of a bipolar diagnosis that has not yet been diagnosed, so an undiagnosed bipolar disorder. And because that's one of the common responses to serotonergic medications in people who have bipolar, is that they get this kind of gross, agitated, unpleasant response to serotonergic medications, and then have a surprisingly good response to mood stabilizing medications like lithium, valproate, carbamazepine, olanzapine. So just something worth exploring. Okay, now let's talk about these special populations. So in people with renal impairment, there rarely needs any dose adjustment, and if you are getting hemodialysis, the dialysis process doesn't remove the medications, so you don't need to adjust your dosage or your timing. Geez, I don't know if I've mentioned this now, but it's a really important thing to take this medication in the morning if you're not sure about it. Most people find it gives energy, and so if you take it at night, it'll affect your sleep. Sorry about that tangent. In liver disease, though, you will usually have to adjust the dose, and it depends on the severity of the liver dysfunction. So talk to your doctors about that. In people who have had recent heart disease, the early research suggests that fluoxetine is safe, and actually if they've recently had a heart attack or angina, it actually improves outcomes, because theoretically, it's not clear, but it might be that it improves mood, which improves engagement in treatment and healthy lifestyle decisions, and then you get better outcomes. So it could be really important. In older people, important to start at a low dose and increase slowly, and actually a very low dose, something like 5 or 10 milligrams might be sufficient to get a response, and actually going higher might make things worse. So important to note. We talked about that SIADH, where the serotonin can affect your sodium levels. So that's something that needs to be monitored with blood tests. So I would say definitely doing a baseline blood test, and then kind of depends on your doctor, but maybe at 1 month in, or if there's any symptoms of confusion. I mean, if there's any symptoms of confusion, you need to urgently go see a doctor and consider going to hospital, especially if there's no background of cognitive impairment. That would be worrying. So just go to hospital if you're worried. And if you're using really small doses, then just make sure you're getting the kind of not the capsules, but the tablets where you can crack them in smaller bits. When using in younger people, like children and adolescents, always important to have a shared decision-making approach with the guardian, and that essentially means weighing up the risks and benefits of the medication with the risks and benefits of not taking the medication, and having a think about how it would, whether it is justified, because there's risks with taking it and there's risks with not taking it. So you just need to have a kind of comprehensive, personalized, targeted decision about the young person, and be really specific on what symptoms you want it to improve, and monitor for those symptoms. So write them down, use a scale. So you can even, there's lots of different scales out there for different kind of things. So if you're talking about anxiety, then the SCARED scale, SCARED, SCARED, monitors for different types of anxiety, and is useful for monitoring. And then repeat that scale and see if it's actually working. Because if it's not working, then you should take it off. You need to think about whether you need a dose increase, a switch, or to take it off. Because you don't want to be on a medication if it's not doing something. Especially with the side effects I've mentioned around kind of nausea and sexual side effects in teenagers, that can be really serious. So if someone is pregnant, this is a very tricky one, because it's not ethical to run controlled trials with a placebo or a medication in women who are pregnant. So the information is incomplete. And similar to with young people, you need to do a risk-benefit analysis. Certainly the highest risk period is the first trimester, when all the organs are forming. And then the second highest risk period is the third trimester, just before delivery, where the baby can have a kind of withdrawal effect after birth if they've been exposed to fluoxetine. So fluoxetine does cross the placenta and the baby is exposed to it. And you just need to work with your treating team to see if the risks and benefits are justified to continue on it. I guess just to be really clear, there's no clear evidence of harm in any studies. So the wording on this textbook is that the current patient registries of children whose mothers took fluoxetine during pregnancy do not show adverse consequences. And you can imagine that if someone is depressed in pregnancy, that could have a major impact on the child, right? If you're not eating, if you're not sleeping, if you're not attuning to your child because of depressed mood or severe anxiety. So you've really got to think about, actually, if it helps you stay in a good mental state. If you think about the risks associated with postnatal depression, then in many cases it's absolutely necessary, and with just good perinatal monitoring and a perinatal mental health team involved, the outcomes can be positive. If you're in Australia, you can use the service Mother's Safe, which is kind of like an advice line around medications and can provide you a second opinion. And I'm sure that there are equivalent services in many other countries. So just kind of type in mental health, antidepressant, pregnancy advice and see what is available in your country. So now with breastfeeding. Look, I think from my reading, every single drug I've read about finds its way at some amount into breast milk. So you kind of have to monitor the baby and see the response. You can try and time it so that you're, doing expressing milk before you're taking the medication, but it's such a long half-life, fluoxetine, that actually your blood levels stay pretty stable if you're taking it regularly every day. So actually, if there's adverse effects in the child, you either have to discontinue breastfeeding or fluoxetine. That needs to be discussed with your doctor, and again, you just have to monitor. You have to consider the risks and benefits of continuing one or the other. But again, I would just make the point that postpartum depression is a very significant thing, and the postpartum period is a very high risk time, and many mothers do breastfeed whilst taking fluoxetine. All right, guys, thanks for tuning in till the end. If you enjoyed this kind of content or found it helpful, please consider leaving the video a like, just clicking on that button, and subscribing to the channel for more content like this. And if you have any questions, comment down below, and bring them also to your care provider so that you can discuss it at a personalized level. But we'll leave it there. Okay, bye for now.